Heart sounds are a fundamental component of cardiovascular examination and an essential topic for MBBS students preparing for clinical practice and licensing exams in the United States. The normal heart sounds, S1 and S2, are produced by the closure of cardiac valves during the cardiac cycle. S1 corresponds to the closure of the mitral and tricuspid valves at the beginning of systole, marking the transition from ventricular filling to ventricular contraction. It is best heard at the apex of the heart. S2 results from the closure of the aortic and pulmonic valves at the end of systole and is best auscultated at the base of the heart. Physiologic splitting of S2 occurs during inspiration due to increased venous return to the right heart, which delays pulmonic valve closure. This is a normal finding in young, healthy individuals. In contrast, pathologic splitting patterns, such as wide splitting, fixed splitting, and paradoxical, reversed, splitting, suggest underlying cardiac abnormalities. For example, fixed splitting of S2 is classically associated with atrial septal defect, whereas paradoxical splitting may be seen in conditions that delay left ventricular emptying, such as left bundle branch block or severe aortic stenosis. Beyond S1 and S2, additional heart sounds provide further diagnostic clues. S3, often referred to as a ventricular gallop, occurs in early diastole and is caused by rapid passive ventricular filling. While it may be physiologic in children, adolescents, and pregnant patients, in adults over 40, it is commonly associated with volume overload states and systolic heart failure. S4, or the atrial gallop, occurs in late diastole due to atrial contraction against a stiff, non-compliant ventricle and is frequently linked to conditions such as long-standing hypertension or hypertrophic cardiomyopathy. Unlike S3, S4 is almost always pathologic and is absent in atrial fibrillation due to the lack of coordinated atrial contraction. Heart murmurs are prolonged sounds produced by turbulent blood flow across cardiac valves or through abnormal intracardiac connections. Murmurs are classified based on timing, systolic, diastolic, or continuous, intensity, graded I to 6, pitch, configuration, crescendo, decrescendo, holosystolic, location, radiation, and response to maneuvers. Systolic murmurs include conditions such as mitral regurgitation, holosystolic murmur radiating to the axilla, aortic stenosis, crescendo-decrescendo murmur radiating to the carotids, and hypertrophic obstructive cardiomyopathy, which increases with Valsalva maneuver. Diastolic murmurs are always pathologic and include aortic regurgitation, early decrescendo murmur, and mitral stenosis, opening snap followed by a diastolic rumble. Continuous murmurs, such as those heard in patent ductus arteriosus, persist throughout systole and diastole. Understanding heart sounds requires integration of cardiac physiology, hemodynamics, and clinical examination skills. Proper auscultation technique involves using both the diaphragm, for high-pitched sounds like S1, S2, and most murmurs, and the bell, for low-pitched sounds like S3, S4, and mitral stenosis. Patient positioning, such as left lateral decubitus for mitral stenosis or sitting up and leaning forward for aortic regurgitation, enhances detection of specific murmurs. For MBBS students in the United States medical system, mastery of heart sounds is critical not only for bedside diagnosis but also for success on USMLE examinations, where clinical vignettes often rely on precise recognition of murmur characteristics and splitting patterns to identify underlying pathology.